I'm Priya Desale from Tata Health Science College. Uh, Today, we need to share our research finding, which is done from cervical cancer. So the title is Cervical Cancer Screening Uptake and Associated Factors Among HIV Positive Women in Ethiopia. Is a systematic review and meta-analysis which has been done among HIV positive women. Here are presentation outlines. We do have introduction, methods, objectives, results and discussion, conclusion. Lastly, acknowledgement. So as we know, cervical cancer is the second leading cause of maternal mortality, which is mostly gynecoid related disorder that can be caused by human papilloma virus. So it is a global public health concern with high incidence, especially in sub-Saharan Africa. It is estimated that around 43 up to 69% of women are died due to this cervical cancer. In most of the developing countries, both morbidity and mortality associated with cervical cancer is nowadays increasing as evidences indicated. But cervical cancer is potentially preventable and treatable forms of cancer, which means it do have a different measures that can be prevented and we can also treat. But unfortunately, most of the mothers in developing countries come into health facilities at a late stage after the disease becomes worse. That makes the disease to be difficult for its controlling and treatment. Women living with HIV have a greater incidence of human papillomavirus infection than the general population. There are a number of studies or evidences that revealed those individuals who have HIV do have greater incidence to be infected by human papillomavirus than the general population. They are also more likely to develop an increased risk of pre-malignant lesion of the cervical cancer or extra epithelial lesions. Immunosuppression with low CD4 counts predisposes women living with HIV infection to high risk of cervical cancer. So those individuals who have HIV are expected to have immunosuppression, and most of them do have low CD4 counts. So this condition will predispose them to develop cervical cancer easily. That's why we need to make more cancer. Cervical cancer and HIV co-infection could be more prevalent in developing countries where ART service is challenging and other services are existing challenges, because those individuals who can have antiretroviral therapy was expected optimal, they can simply protect themselves from human papillomavirus. But whenever there is a law or a challenge in ART service, their chance to develop cervical cancer is very high. Morbidity and mortality could be reduced with early detection and with effective management. We have said that cervical cancer is preventable and treatable, but it can be true whenever individuals are early detected and given empirical management early. So the WHO cervical cancer prevention and control guideline has been developed in 2013, and Ethiopia also adopted, and it recommends all women needs to be screened at least every 5 years with a negative result or after a negative result. But unfortunately, in Ethiopia, the prevalence or the pooled national prevalence of cervical cancer uptake is unknown. Of course, there are fragmented reports with wide range of prevalence of cervical cancer, from 7.8 in Alamata Generalized Hospital to 40% one in Hawassa town. So these are a wide range. this variation has not been examined systematically. Therefore, this study was aimed or designed to estimate the pooled prevalence of cervical cancer screening and its associated factors among HIV positive women. This study do have at least two major objectives. So the first objective of this study is to determine the magnitude of cervical cancer screening uptake among HIV positive women in Ethiopia. And the second objective of this study is to identify factors that are associated with uptake of cervical cancer screening among HIV positive women in Ethiopia. Studies which has been included in this study has been screened based on eligibility criteria. So the first eligibility criteria was study area. So those studies which has been conducted in Ethiopia has been included. Regarding study design, all observational studies were considered, but unfortunately, those studies which has been included were all cross-sectional. Studies that involves HIV positive women and reported uptake of cervical cancer screening and or determinants of cervical cancer screening has been included. Those studies which has been written and reported in English language were considered or included. Both unpublished and published articles were considered, and one unpublished article were included lastly. But those studies which were qualitative studies, reviews, commentators were excluded as they didn't report the outcome variable. Studies or articles has been searched from different electronic databases and with the support of manual searching, potentially relevant articles were searched from PubMed, Scopus, Science Direct, and other electronic databases by creating a mesh word. So the search was carried out based on the following key words or mesh words: uptake, utilization, cervical cancer, cervical neoplasm, and other such a kind of key terms has been developed based on mesh terms in PubMed search. So the search terms were applied using Boolean operators and other truncations like or, and those terms or mesh terms having similar characters has been connected with or, and the others has been combined with and. The search was conducted from 8th of May to 24th of May of 2020. After searching, the study were selected. There are a number of articles has been retrieved and the duplicates were removed based on EndNote X7 software. After removing the duplicates, the articles has been screened based on their titles and abstracts. After screening, those studies which are not eligible based on their titles and abstracts were excluded, and those studies which do not have a criteria to exclude or include them were screened for their eligibility based on their full texts. Prisma flow diagram was used to summarize the study selection process in general. The risk of bias or assessment has been also done for each studies which has been included for this systematic review and meta-analysis. Joanna Briggs Institute Quality Review instrument was used, which has been adapted for cross-sectional studies. The tool may include criteria for inclusion if detailed description of study subjects and setting, reliability and validity of study tools, representation of population, the methods they used, and acceptability of case definition or operational definition they used or each individual study has been used, and identification and dealing of co-founders, and the response rate, the sample size. All these conditions were used for assessment of risk of bias for each included studies. After assessing the quality of the studies, data were extracted from the selected primary studies. The relevant data were extracted by using Microsoft Excel spreadsheets. and the important variables were extracted. Among the relevant data which can be used for this study that has been extracted are the name of the first author, study region, setting, study design, sample size, response rate, uptake of cervical cancer screen. That's mostly they reported as a prevalence, and odds ratio of each identified risk factors. Those risk factors which has been reported consistently and having a consistent grouping. Outcome variable of these studies to have two outcome variables. The first thing is uptake of cervical cancer screening. So based on the primary studies report, the lifetime uptake of cervical screening was the primary outcome of this study. The second outcome of the study is factors associated with cervical cancer screening uptake. So variables reported consistently and frequently were selected for as a determinant, and determinants reported in more than one study were selected for this study. Among those variables which has been reported consistently and in more than one study is knowledge of women about cervical cancer, educational status of the women, perceived susceptibility of being or developing cervical cancer was the three factors that was extracted for this study. Lastly, data synthesis and analysis was done. So the data were imported into data version 14 for analysis. So the meta-analysis was done based on or using data version 14. The pooled prevalence of cervical cancer screening uptake were executed with 95 confidence interval. Heterogeneity among states was checked using Cochrane statistics, and it was quantified by I-square statistics. So random effects model was computed as the almost all statistical meta-analysis was having heterogeneity. That's why we used random effects model. Subgroup analysis was conducted based on study settings, and publication bias was assessed using Eggers test and funnel plot symmetry. Finally, while live sensitivity analysis was done, whether a single study has been influenced the estimated results or not. So based on the statistical analysis, the both meta and systematic review was done. When we come to results and discussion, as we have said earlier, state selection was done based on Prisma flowchart. So at first, 10,566, 56 articles were identified from different databases, and 2 studies were identified with manual searching. So more than about 3,641 studies were excluded due to duplication, and the other studies has been screened for their eligibility based on their titles and abstracts. 28 articles were eligible for full text articles, but only 7 articles were included as the other studies were excluded due to different factors, such as the outcome variable were not reported in 6 studies. Variation is study population. They has been done in general population, that's 11 states. And some of the states, like 4 states, has been conducted in other countries. So the study has included a total of 2,822 HIV positive women from estimated sample size of 317 out of 594. All included studies do have a good response rate, which is greater than 90%. Regarding geographical distribution, the studies has been conducted in different geographical areas of the country or Ethiopia. 2 studies has been conducted from Amhara region, 2 was from Addis Ababa administrative city, and 1 study from Oromia, Tigray, and Southern Nations, Nationals and Peoples region. So the study may not be representative as all regions were not included. So when it comes to the pooled estimate of or the prevalence of cervical cancer uptake among pregnant, HIV positive women, uh, around 18% of HIV positive women has been screened for cervical cancer, right? As you can see from this picture, just 18.17% of HIV positive women has been screened for cervical cancer, which is very low from the recommended percent. So this result or this finding is higher compared to a study done in Nigeria, which reported 9% of HIV positive women has been screened for cervical cancer, and Morocco, which is equal, 9% of HIV positive women has been screened for cervical cancer. However, this finding is very lower than study finding conducted in England, which reported more than 85% of HIV positive women has been screened for cervical cancer. In Spain, more than 50% of HIV positive women has been screened for cervical cancer. And even in Kenya, 46% of HIV positive women has been screened for cervical cancer. So this variation might be due to different factors, such as difference in access to reproductive health service, community sensitization and awareness raising program on cervical cancer. There might be difference in cervical cancer screening service quality by itself, or it could be differences in socio-demographic status of the study participants. And most cited possible justification is it could be due to variations of countries' promotional enhanced national advocacy and media concern regarding community mobilization, sensitization about cervical cancer screening service. And there are different factors that can simply influence cervical cancer uptake. HIV positive women who had formal education were about 3.5 times more likely to be screened for cervical cancer than those women who do not have formal education, which means those individuals who have formal education, primary education, secondary education, university education, have more likely to be screened for cervical cancer. This study is supported by other studies, and the possible reason could be understanding of the prevention of the disease, or which can be given from healthcare workers or mass media, can be simply comprehended by those individuals who are educated, or those education might also increase motivation in search for health intervention and information gathering. Those individuals who are educated may not be worried about social inclusions, so they can be simply found cervical cancer screening service. As you can see from the picture, the pooled odds ratio is 3.5%. The other factor that's significantly associated with cervical cancer screening among HIV positive women is knowledge of women regarding cervical cancer. Therefore, HIV positive women who had good knowledge of cervical cancer were about 3.46 times more likely to be screened for cervical cancer. So this study is also supported by different previous studies, which has been done in other countries. So this might be due to the fact that having a good knowledge about said disease or cervical cancer would encourage individuals to seek help, or it can create better health-seeking behaviors. So those individuals having a better health-seeking behaviors will intend to get screening service before the disease becomes worse. The third factor that significantly associated with cervical cancer screening among HIV positive women was perception. HIV positive women who had high perception of susceptibility were about 3.26 times more likely to be screened for cervical cancer, which means if individuals or women who perceive themselves as the risk for developing cervical cancer are about 3 times or more than 3 times more likely to get the screening service, which can be supported by other previous studies. So the possible justification could be that women who perceive themselves as susceptible to develop the disease could be motivated for screening before the disease becomes worse, because they need to be uh, prevented from such a kind of disease. Studies or evidence indicated that self-vulnerability to illness is an important predictor of early screening, right? If individuals believe or perceive themselves as a risk for disease, they can be simply get screening service before the disease becomes developed or worse. When it comes to this study do have its own limitation, right? The limitation of this study is important source of heterogeneity were not fully addressed, actually, because it was designed to perform subgroup analysis based on study regions, but the included studies in some countries are only one, but it's very difficult to port such a kind of prevalences in meta-analysis. That's why important sources of heterogeneity were not fully addressed. Some predictors or risk factors were not examined because the primary studies has been reported inconsistently and with different categories. And the other limitation of this study is temporal relationship between predictors and the outcome variable, which is cervical cancer, cannot be established as all the included studies were cross-sectional in nature. And the last limitation of this study could be the pooled prevalence may not be representative in all the regions of the country, as the included studies were only some regions of, or 4 regions and 1 administrative city. Conclusion, this study found that cervical cancer screening uptake among HIV positive women in Ethiopia is very low, and the likelihood of cervical cancer screening uptake was higher among HIV positive women who had formal education, who had good knowledge about cervical cancer, and had high perception of susceptibility to develop cervical cancer. Therefore, based on these findings, we suggest some recommendation for those programmers, policymakers, healthcare providers, and other stakeholders who are concerning on cervical or working in cervical cancer prevention strategies. So improving the existing national strategy of cervical cancer is strongly recommended. We do have a national strategy based on guideline, so improving uh, regular monitoring and evaluation is very essential. And the other recommendation that we need to provide for especially policymakers and programmers is and healthcare providers is providing health education and community sensitization in addition to providing screening service. Because most of the time, uh, uh, we only concern about the screening service, but we do have lack information on how can we sensitize community in general. And the other thing that we strongly recommend is cervical cancer screening service should be integrated to the routine care and treatment or in ART service. So those women who are coming for ART service are better to be screened for cervical cancer as well. And lastly, monitoring and evaluation on detection of cervical cancer and prevention activities has to be or should be regularly done. We do have acknowledgements. The authors would like to acknowledge those authors of primary stages, because we get the information from the primary stages. There are sample references. Thank you very much.